Okay, everyone. Well, welcome to the Geriatric Emergency Care Applied Research Network session focused on our scoping reviews and stakeholder consensus updates. Thank you all for joining this session, which we will start right away at 3, only because we have a power-packed panel and lots to discuss. To begin, oh goodness, it's not advancing. Hold on. I really want to acknowledge, and you'll hear shortly from the GEAR core leads. GEAR would not exist without the leadership of these individuals and many others that are not actually on the panel. You'll be hearing from Chris Carpenter, who will be talking about delirium, Will Hung, who will be talking about falls, Tim Platts-Mills, who will be talking about elder abuse, and Nikki will be talking about transitions of care. The goal of our session today, hold on, is really for you to learn more about what GEAR is all about, its aims and objectives. Many of you already know about this. To summarize the latest interdisciplinary stakeholder research priorities in geriatric emergency care and discuss our current research activities and future funding opportunities with the GEAR network. So what exactly is GEAR? Well, we're very fortunate. GEAR is an NIA-funded phased award. Our mission is to build a research infrastructure for interdisciplinary aging studies focused on geriatric care in the ED. We have several aims, of which one of the first is really, and you're going to hear most of it today, is to establish the research priorities, develop measures and standardized approaches for geriatric emergency care syndromes, and from this, move forward and build a data bank that would have standardized measures that several can use, hopefully, for multi-center studies. The goal is, of course, is with this database is to build preliminary data and support future studies and applications by you all to move forward best practices in geriatric emergency care. As I said before, GEAR is a phased award. We're actually now in the R33 phase, but the first 2 years when it was an R21 focused on scoping reviews in 5 domains and research priority areas of geriatric syndromes: cognitive impairment, care transitions, med safety, falls, and elder abuse. This is what we did over those first 2 years. This is just a timeline of the extensive work done by a very large group of task force members to conduct scoping reviews. It culminated in a consensus conference back in October of 29 to really review the research gaps that we identified and come to consensus around what the research priorities should be. Several of these groups have now published those papers, and you'll hear more about exactly what was discovered in those papers in today's session. This is the consensus conference itself, which again took place back in October, and we had a very large group of stakeholders in the task force participate and attend, almost 50 people at that meeting. And it was a wide representation of individuals. I think what's key to geriatric patient care is it doesn't sit on one discipline or one specialty's shoulders. It's really a partnership across different disciplines and also different levels of expertise and seniority. So from physicians to nurses in geriatrics and emergency medicine, to pharmacists, social workers, researchers, med students, all the way up to senior level researchers and administrators. Key themes that emerged from that meeting, and I think this is critical and across the spectrum for geriatric emergency care, is that in essence, older adults that come through our emergency department are a heterogeneous group. And so what we really need to do is identify those that are at highest risk. We also discussed that it's really the discharge patient that's the vulnerable patient that we'd be most concerned about. So what happens to them after they're discharged out of the emergency department? And when that happens also, what are the optimal outcomes we should be studying? The typical outcomes that we're most used to thinking about with regards to healthcare utilization, we may or may not find differences in that. And several studies sometimes indicate that there's a null effect. So what is really more important is now actually patient-centered outcomes. There was a common consensus that function, quality of life, and even access to care, such as connections to PCP after the ED discharge, may be more important and critical outcomes to be looking at. And for that reason, the timing of those outcomes will be also important. I think from the ED perspective and stance, we're really used to the first 3 to 4 days after the ED visit. But for some of these things, when we're looking at older adults, it also may be important to take into consideration things that happen anywhere from a month later to 3 months later after an intervention might be done on older patients in the ED. And then finally, there was consensus in the importance of leveraging our electronic health records. So using the data from there with regards to automation, or even using it to flag high-risk patients. So now I'm going to move forward and talk about med safety. So with the med safety group, I'm going to talk, and I have no conflicts of interest to disclose. So why is med safety important? Well, as we know, and you're going to hear in all the sessions, older adults are predominantly becoming a larger group of patients that we're seeing in emergency departments. For the majority of these patients, though, many, we hope, won't necessarily have to be admitted, and many may be discharged from the ED. What we also know is from the emergency department setting, many of these patients may receive a new prescription at the time of their ED discharge. What we also know, though, unfortunately, is if we do prescribe a medication, there may be suboptimal prescribing and pharmacotherapy. And for those patients who have suboptimal prescribing, they are actually at greater risk for earlier adverse events. And this is actually data that Nikki Hastings presented from VA evaluation. So if we go back to what the GERI ED guidelines really recommend, it is important for us to make sure that we know what these patients are taking, have a good review of their medication list, and especially those that are with polypharmacy and on multiple medications, be attentive to what might be potentially inappropriate in terms of medications, or those medications they might be on or be receiving that might be high risk. It's important for us to use our resources. And so for those of us who have pharmacists in our EDs or have the opportunity to work with geriatricians, to really come up with ways and plans to identify those high-risk medications. So for the med safety group, we really focused on consensus. There are many questions that we could have addressed and studied, but we really honed down to the 2 questions around what medications should be avoided in the ED setting for older adults, and what definitions, would define something that's potentially inappropriate or unsafe, and what criteria to use for those. And then finally, what are some of those critical outcomes that we should be looking at to determine if something is considered safe or unsafe. We use the PICO process, and with the PICO process, where you look at population, intervention, comparison, and outcomes, and you're going to hear more of that with the subsequent groups. For the med safety group, the first PICO looked at use of Beers criteria, protocols, or interventions, and what were the impact on outcomes from patients in the ED. Almost close to 3,000 studies were identified in our scoping review search, and we drilled down to 5 that had key information. And the information we extracted from these 5 papers is in essence found that for the most part, pharmacists reviewed medications in the ED. They used things like the stop-start criteria or the RASP criteria, or what was defined as high-risk medications. And another type of form to help with med safety also used physician order entry. What these studies found is while the pharmacists often identified high inappropriate prescribing rates, there was actually very low acceptance of their recommendations by the clinicians. And when the physicians had physician order entry, they actually didn't use it often either. So there's low acceptance of use of those. In terms of the impact, the results were also mixed, and really finding no difference in impact on greater risk for admission, ED lengths of stay, falls, or even things like mortality. In our second scoping review, what we found, and this one focused specifically on supports to the clinicians to avoid inappropriate medications, 500 papers were identified, and of those, we found 15 that we had information that could be extracted. With the interventions identified here, similarly, also use of pharmacists to review medications, computerized decision supports, and academic detailing. So in this case, giving clinician reports on their performance of whether or not they were prescribing inappropriate medications or not. This review also found mixed results. Some of these studies, those, for example, with pharmacist review, found that, yes, there were some reduced risk of adverse drug events. Others found reduced admissions, but then majority of the other papers found really no effect on similar outcomes. And so again, mixed results. When it came to computer decision support tools, several of the studies did find maybe a reduced use of potentially inappropriate medications, maybe with better dosing and lower rates of adverse drug events. But for the most part, the computer decision support continued to be declined. So up to 92% of the time it was just not used or ignored by the clinicians. Academic detailing in a multi-center study, this was actually the EQUIP study, did find that there was a reduced prescribing of potentially inappropriate medication use. So in summary, for the med safety group, what was discussed based on those scoping reviews and from the consensus conferences, key research priorities should focus on identifying those patients that are at highest risk for med safety adverse events, identifying which medications should be avoided and what are some of the safer alternatives for targeted patients, what outcomes should be used to assess ED med safety, what models or how are models that are currently working, how can they be further disseminated, and who and what partners could positively impact desired patient-centered outcomes. Since these priorities were proposed at our consensus conference, one of the members of the med safety work group, Nada Hamuda, did come out with a paper that just was published this past year actually addressing one of these questions. And it looked at beers versus non-beers prescribed medications for older adults discharged from the ED. And what she found was actually patients who are prescribed potentially inappropriate medications, if you use the Beers criteria, are not actually at increased risk for ED revisit or subsequent hospitalization. In fact, what she found was patients who are prescribed potentially inappropriate medications were actually at a slightly decreased risk for hospitalization in the subsequent 30 days. So sometimes these results may surprise you. So next steps, we are trying to draft a summary of the findings from that consensus conference meeting and our scoping reviews. And a key lesson learned for me is if any of you are doing any kind of review, whether it's a scoping review or a systematic review, the timeliness of trying to get that paper out. Because when we completed our scoping review, it ended in 2018. And so we are now currently in the process of having to update our literature review to make sure that we are catching up for the last 2 years that have gone by. So now I'm going to, and I'd like to just acknowledge and thank this GEAR task force, as you saw on the slide. It's a very large group and we had many members involved in the med safety group, and I just wanted to acknowledge and thank all of them for their contributions. So now I'm going to hand the baton to Chris Carpenter.
Thanks, Eula. So I'm going to talk about our work group, which looked at delirium, and we didn't start by thinking about delirium. We thought about dementia as well, but ultimately figured that delirium was more of a brain emergency, more pertinent to our emergency colleagues. Next slide. My conflicts are that I have some funding support, and I also serve on the SAM Board of Directors, the ASAP Clinical Policy Committee, and the editorial boards for Academic Emergency Medicine and the Journal of the American Geriatric Society. So some intellectual biases to consider. Next slide, please, Eula. So first thing is, why should you care about delirium in the emergency department? And I would put forth a few reasons. One, prolonged ED length of stay decreases our ED thoroughfare and our financial bottom line for sustainability as a department. Number two is altered mental status often leads us down the wrong path with incomplete history or inaccurate history, and that can be a malpractice risk and certainly sets us up for patient dissatisfaction. Number three is that some of these ED returns are preventable if we could recognize delirium during a point of care, and certainly if we could prevent delirium post-ED care. And it really is a dissatisfier to patients and families when they have a delirium episode in the emergency department. So an opportunity for us to really improve the process of care for our patients and our families. And number four is it's just the right thing to do. An episode of delirium is extremely unpleasant, and it does reflect on patient satisfaction surveys. And it does not bode well for our specialty if we do not deal with this issue. Next slide, please. I did want to take a little bit of a walk down memory lane just to let the audience know that this is not the first time that we've prioritized research for geriatrics. We did this back in 2006, and actually a bit different format in that we relied on 2 individuals to go through the literature rather than this team of 50 that GEAR put together. But this is a historical reference mark for you to show how much progress we've made in some of the areas that we're going to be talking about today. Next slide. I also wanted to briefly discuss my lessons learned with the grants for early medical and surgical specialist transition to aging research, where I had the opportunity to co-lead meetings for 3 years across all medical and surgical fields, doing early stage investigator geriatric research. And a lot of these concepts that we're talking about came up across all specialties. So some of this is not very specific to emergency medicine. And I think there's going to be some team-based science opportunities in the future to really explore some of these questions in more detail outside the emergency department. Next slide, please. The rest of my presentation, fortunately, has been published already. It was in the January issue of Academic Emergency Medicine. So you have a frame of reference you can go to get some of these details for things that I don't have time to cover in the short few minutes that we have. Next slide. Each of these teams, like Eula said, started with a PICO question and actually a series of PICO questions and narrowed those down to 2 so that we can get those done within the year timeframe that we had. The delirium group focused on, number 1, the accuracy of identifying delirium in the emergency department, including with clinician gestalt or with traditional clinical decision rules. And we actually found 48 studies, including 8 conference abstracts, which analyzed 27 different delirium instruments. And then the second question was, how effectively can an ED intervention reduce the incidence or severity of delirium? We always start with this assumption that once we identify it, that it's modifiable, that we can do something about it. And I certainly hope that's true, but can we prove that? So PICO 2 actually identified 15, only 15, but 15 intervention studies looking at treating or preventing delirium in the ED, but could find no consistently beneficial pharmacologic or non-pharmacologic strategy to reduce the incidence, duration, or severity of ED or post-ED delirium. Next slide. One big strength of this manuscript, I think, is that it is a one-stop resource for all the delirium instruments that have ever been tested in the emergency department. And I can't think of another single source, textbook, online, MedCalc, or article that has summarized these all in one place. So be sure you check out Appendix Supplement 3. Next slide, please. But wait, there's more. If you buy right now, there's more. It's Appendix S4. S4 actually provides a pragmatic breakdown of the pros and cons of each delirium screening instrument through the lens of an emergency physician. What are the advantages and disadvantages of each instrument if you were to take it and use it in your shop tomorrow? So that's also a nice advantage of this manuscript. Next slide, please. But remember, our second question dealt with, how do we do something about this delirium that we've detected? I think we've shown there's lots of instruments that have been developed. Many of them work quite well to identify high risk or low risk for delirium, but how well can we prevent delirium? And I think our results here are a bit surprising. Next slide, please. We actually found there are 7 systematic reviews in Cochrane database. Next slide, Eula, this will click through. There are 7 systematic reviews that test different interventions in different settings for the prevention or treatment of delirium. And surprisingly, there is not a consistent treatment or preventive therapy that really does effective prevention or treatment of delirium. But I bet there will be some based in the ED very soon. Next slide. So the absence of evidence, I believe, is not evidence of absence. And I think that there are opportunities for us to learn from what the void of evidence we have for treatment of delirium. And we're going to talk about some of those next. Next slide, please. So the remaining time that I have left, which is I think about a minute, I just want to focus on these 7 areas that our GEAR group elected as the highest priority research priorities. Number 1 being the highest priority, number 7 being the lowest priority. Number 1 was detection, and detection using resources that don't involve the nurse or physician time, because that's the most valuable commodity that we have. Another priority, number 2, is a prevention using some sort of automated system to prevent delirium by detecting this delirium using maybe smart logic or machine learning. Number 3 was lumping together delirium and dementia and just worrying about whether we can identify cognitive impairment in the emergency department. And number 4 was develop some sort of a PCAR network-like multi-institutional repository of delirium cases to do some hypothesis testing for future grantees to build a data infrastructure and really start to accelerate the growth of delirium research in the ED. Number 5 was building for implementation and designing studies from the outset that are going to be reproducible, whether you're in a rural setting or an urban setting, an academic or non-academic setting, to test fidelity of the delirium testing or intervention, adaptability, and sustainability. Number 5 was phenotyping. That's identifying the delirium subtype based on the pathophysiology and anticipated trajectory of delirium. And then number 7 is targeting the therapies at the specific delirium phenotypes that we've identified in the ED. To me, those 2 ideas, number 6 and 7, are the most exciting because I think that those 7 failed Cochrane database reviews indicate that we can't treat delirium as a one-size-fits-all type of problem. Next slide. Fortunately, there's a lot of individuals thinking very similarly about this from the American Delirium Society, NIDIS, and NIA Collaboratory. We're going to have a slide at the end that presents those, but I just want to thank all of my co-authors. This is an extensive amount of work and a heavy lift. And with that, I turn it over to Will, I think. Next slide.
Yes, Thanks, Chris. So hi, I'm Will Hung. I'm a geriatrician and health service researcher from Mount Sinai. Next slide, please. This is disclosure of my other interests in terms of my research interests and academic interests. I also serve on the board for Aging in New York Fund and also Public Policy Committee for American Geriatric Society as well. Next slide, please. So this group actually as work is pertaining to falls. So why do we care about falls? I think I'm preaching to the choir here that we do know that there are plenty of older adults that actually present to the emergency department annually after a fall. Some of the latest statistics, over 2.8 million older adults annually actually present after a fall. And injurious falls actually often result in reduced mobility, functional decline, mortality, actually downstream impacts after presentation falls. So some of the, and also actually, we do know that a lot of older adults actually present after the initial presentation of fall, they come back actually with recurrent falls, and some consideration may be that falls may be preventable in the ED setting. Next slide, please. So given the mortality and mobility that is associated with falls, there has already been quite a bit of interest within emergency medicine to address falls and initiate ED-based fall prevention efforts. So the Society of Academic Emergency Medicine, also going down the memory lane as quoting Chris, that over 10 years ago has actually recognized fall prevention as one of the 3 priority areas. And 2010 guidelines for emergency medicine resident core competencies also specifically address the need for understanding how to recognize fall risk factors and prevent falls as well. More recently, in terms of the Geriatric Emergency Department accreditation process, also cites fall prevention as an option for a quality improvement project for accreditation, and later on also recommended initiation of multifactorial fall prevention for ED adults, ED patients with falls. Despite these recommendations to prioritize sort of efforts targeting falls, there's still lack of consensus about which fall assessment management tools, what interventions are most actually feasible and effective in the emergency department. So this has resulted in our scoping review process that we have actually conducted through the GEAR project. So this has actually resulted in a, this has also been published, and this is hot off the press, actually just came on 2 days before on the website for American Emergency Medicine. So please do, if you have a chance, do take a look on the online first portion of it. Next slide, please. So similar to the previous groups, we have used people questions to guide our research and the scoping review. So we have selected among a lot of questions related to fall prevention management, and voted amongst the task force members, and to use these 2 questions. The first question is actually pertaining to the effective thinking about effect of fall prevention interventions in the ED and also in the peri-ED period, and its impact on and its effect on recurrent falls, ED return for falls, and other outcomes as well. The second question is pertains to the effect of risk stratification. So using different tools for to stratify risk, and then followed by a falls care plan in the emergency department and its impact on falls and similar outcomes. Next slide, please. Our first question actually resulted in over 3,000 abstracts, and the second question resulted in over 2,500 abstracts, which boiled down to 32 studies that we included for a PICO-1 search and 19 studies in PICO-2 search. So in the scoping review, the previous slide, please. Sorry, Hila. So what we have found is that actually there are several lessons that actually we've learned from the scoping review. We did actually find that interventions are often bundled. With multiple components within the bundle. It may be, patient and clinician education combined with referral for physical therapy, or it may actually even extend beyond the ED period, like follow-up phone calls or even home visits by nurses and physical therapists. Which is potentially challenging to identify what specific components and what the effect of each of these components are. We also found that the outcomes are quite varied as well, even though recurrent falls, a rate of recurrent falls is the most common outcome that's being used to evaluate the effectiveness of the interventions. But the duration of follow-up actually did vary. And also the way that fall is ascertained is actually also vary across studies, such as the use of diaries, whether there's caregiver report, a self-report, or other measures, other ways of actually ascertaining measurements. The third lesson that was actually that we saw was that there are actually a little comparison of false risk assessment tool across in studies. One risk assessment tool may not actually be pitted against another in terms of comparative cost, in terms of its feasibility and also its performance characteristics as well. And the last observation was that actually there are quite limited studies on around the surrounding the ED period. So, for example, it would be actually before somebody actually presents in the emergency department, such as when EMS presents and takes patients into the emergency department. That there is actually very little information, little attention paid to how that could actually impact falls prevention and recurrent falls prevention as well. Next slide. So, previous slide. Yeah, so with the consensus conference, we have identified several top ranked consensus questions similar to the medication safety group and also the delirium prevention group. Some of the questions are consideration of EMS, emergency medical services role in peri-ED care, thinking about hospital assessment, screening, and intervention. So what role does it play in false assessment, screening, and intervention? Identification of assessment tools. So what is the best assessment tool in terms of feasibility and performance characteristics to identify fall etiology to inform targeted interventions? The third area is a consideration of patient prioritized outcomes. So what patient prioritized outcomes need to be considered. And together with that, also consideration of what optimal outcomes there are and how to determine that and how to actually measure those. And last is actually consideration of the fall interventions themselves in terms of the fall intervention components and also effectiveness. Should they be tested as a bundle, separate components, and what should be in the bundle as well? So next slide. Just want to thanks to the falls team and for which this work would not have been possible. Next slide. I believe I turn it over to Tim.
Yeah, thanks, Will, and thanks, Eula, for organizing this. I'm Tim Platts-Mills, emergency physician, and currently working with a data analytics company leading their healthcare and life sciences program. Next slide. I have disclosures related to NIH and related funding for which I'm leading or consulting on. Towards the bottom, you'll see I led the development of the ED senior aid tool, so that's an intellectual conflict of interest. And then I work for a private company, which is a potential conflict of interest. We have some interest in the elder abuse space, and I also am a decision editor for Annals of Emergency Medicine. Next slide. So why do we care about elder abuse? I think it's probably one of the least appreciated major health problems in older adults. Really, so if you study older adults and you call them up and you say, tell me in the past year if you had a problem with elder abuse, the rates in the United States are around 8%, and that's been replicated in several studies. So, the lowest numbers we're seeing around 6%. So the 1-year prevalence is high. When we've done this in the emergency department, this is 2 separate studies. We got between 3 and 4% of patients who said, currently right now, based on, well, they didn't say this, we assessed based on their responses to questions that we think about 3 to 4% of these older adults are currently experiencing elder abuse, to the point that we think a social worker should see them and that we need to do something about it, during today's ED visit. If you, the 1 every 2 shifts, that might not be quite right. If you only saw older adults, that would be true. You may feel like you only see older adults, but you probably don't. Abuse profoundly, not surprisingly, being abused is not much fun. It profoundly affects health and quality of life. It's associated with increased healthcare utilization, and it's also associated with functional decline and premature death. And most of the states in the U.S., so I think not New York, but I think all the other states, maybe not Connecticut, all the other states are mandatory reporters. So we are have a mandatory reporting law. So we are mandated reporters if we identify elder abuse. But I think more importantly, we have the opportunity to intervene here and make a difference. So I think the big picture, that's why we should care about elder abuse. Next slide. We have, like the other people have presented, we have published this work now. So this was published in the Journal of Elder Abuse and Neglect. And I'll say a special thanks to Jay Kaiser. It was a team effort, but Jay really brought it across the finish line. And thanks to Jay for doing that. Jay is a PhD in social work at Michigan. Next slide. So we use 2 PICO questions to guide our search. And the first one was looking at the question of screening. And specifically, we asked the question of what's the role of universal screening versus a targeted approach to screening. And you can imagine a couple different ways to target people. Maybe you have an electronic phenotype, or maybe you have something about the patient based on disability or dependence that would help you kind of focus your screening, versus just usual practice, which would be, usual practice is, I'm a smart guy, I'll probably figure it out. If they're being abused, I don't need to screen them. Okay, so that's usual practice. So that was one question, was different approaches to screening. The other question was, what is the impact of interventions versus usual care? And when we conceptualize usual care, generally what we're talking about is calling APS. An intervention, as defined, as we conceptualized it, would be something more than just calling APS. And here we were interested in sort of the full gamut of safety, health, legal, and psychosocial impacts, recognizing there could be some negative impacts from an intervention. So next slide. So taking the 2 PICO questions separately, the first question, there were no studies that compared screening approaches. And I'll add, and I'll say, sort of generally speaking, doing studies in elder abuse it's fairly challenging, and don't be put off from it. It is methodologically challenging, but it is doable. So no studies compared different screening approaches, which was what we were really after. But there are 4 screening tools that have been either developed for or studied in the emergency department, and those I'll mention here. The Elder Assessment Instrument was developed by Terry Fulmer and colleagues. It's got 41 different observations split up into 5 categories. That was published in 1984. Terry Fulmer today is the president of the John A. Hartford Foundation, is funding research on elder abuse, and that speaks to a lifelong commitment. So thanks to Dr. Fulmer. Identification of seniors at risk, ISAR, was developed by Jane McCusker. The first article was published in 1999. She's based in McGill in Montreal. The ISAR has 6 questions. ISAR has been studied for pretty much everything under the sun, including elder abuse. There are a couple papers on that. Is, as you can imagine, because it's sort of a generic assessment of vulnerability, or a screening tool to identify a vulnerability. It's not specific to elder abuse. And the positive rates in some studies, around 40% of patients are positive for an ISAR, or ISAR-like positive. And most of those people aren't victims of elder abuse. So you just have to realize, if you're using that tool, you're not sort of putting your finger on the exact patient that's a victim. You're finding a subset of patients in which there's likely to be more elder abuse. So it's not very specific. The ED Elder Mistreatment Assessment Tool for Social Workers was developed by Tony Rosen and colleagues at Cornell, published in 2020, I think. Yep. And it has 2 different pieces to it. It has like an initial assessment, which is 11 questions. And then it has a comprehensive assessment that provides a context, and that's 17 questions. it was designed for social workers. I'll let Tony tell you whether or not it could be morphed into something for nurses or other providers. And the ED Senior Abuse Identification Tool, which we refer to as ED Senior Aid Tool, that was developed at UNC 2016-2019 by my team with NIJ funding. It has 6 to 8 questions, depending on whether the patient is dependent. Sensitivity and specificity are fairly good in the study, in the validation study we did. And then, although not published yet, EMSART takes this tool and puts basically a brief screening tool in front of it. So it uses 2 questions up front, and then if those are positive, you do the triggered screen, which is essentially the ED Senior Aid, and then it has a response. And that's currently being rolled out in about, I think, 4 or 5 healthcare systems, plus being explored with the VA system, and hopefully that we'll get some data out on that, on the EMSART in the next year. Next slide. In terms of interventions for elder abuse, again, there are no studies that examine the effect of interventions, so we don't know if you do this intervention, what happens to the patient. There are a lot of interesting questions to ask about what kind of outcomes you should use for these kinds of studies, and it's not as simple as whether they ended up in a nursing home or not, or you could ask some subjective stuff, but some people have talked about these. Asking patients what they care about up front and using that to determine what should be the outcome, which is an interesting approach. There are 5 ED-based interventions that have been described, and these 5 interventions roughly fall into 3 categories. One is multidisciplinary response teams that are based in the ED or in the hospital. The next category would be protocols for physicians, and the third category would be educational interventions for physicians. So that kind of covers the scope of published work in interventions. There is a tremendous need for outcome studies for these interventions. Next slide. So from our scoping review, and based on those PICO questions, we identified 5 questions that we think are really priorities for going forward. One is, what is the role of targeted screening and how would you do that? 2 is asking the question about, can you intervene on caregivers? And conceptually, it's easy to think about elder abuse as being something really horrible, in which case the perpetrators are criminals and should go to jail. Often that's not exactly the case. And certainly I've seen some pretty bad elder abuse where the caregiver is a single mom who works 2 jobs and is poor and is overwhelmed and is neglecting her parent, but it's not really intentional. And there's certainly plenty of elder abuse that results from a son or daughter who has a mental health problem or has a substance abuse problem. And in those cases, there may be interventions that we can direct towards the caregiver that can improve outcomes, presumably for the caregiver and also for the victim of elder abuse. So I think that's a really interesting area of future investigation. I think that the holy grail in all this is doing studies that look at screening interventions and combining them and seeing, can you combine them and make a difference? That's number 3. EMS screening was also identified as an area of interest. The difference with EMS, between EMS and emergency medicine, being EMS are often inside the home, and so they get another look, a sort of a closer look at what the home environment is like. They may see a caregiver or a person with the older adult who might not show up in the ED. So they do see some things that we don't. Brad Cannell in Dallas has an R01 to test what he's developed, which is the Detect tool. He's got some great partnerships there. And if you were to do more work in there, I would strongly encourage you to contact Brad. And then finally, the 5th question is regarding abuse-specific interventions. And so you can imagine there's lots of different types of elder abuse, and we'd want to probably want to tailor the intervention to the type of abuse. And so you could break it down based on the 5 different types: psychological, physical, sexual, financial abuse, or neglect. And that could guide you in terms of interventions. And I think the answer to this question is, should it be specific, is yes. That's probably the right answer. The question then becomes, well, how do you do that? And what do those interventions look like? So those are the 5 priority questions. Next slide. And just as an extra note, there's a huge need for this research, just to reemphasize it. One thing to be aware of, the APS response is highly varied. It is not a federal response. It's not a federally defined response. It is all based on the state and county level. And some places do a great job, and some APS systems don't even call you back sometimes. So you need to be aware that when you're solving the problem in the ED, and if APS, to the extent that APS is part of the solution, it's going to be varied, and so you need to be aware of that. And that's not to criticize APS. The reality is that is a very under-resourced program, unfortunately. And I will just add, from my own perspective, the screening is doable. We need to do more screening. There is a challenge in the reporting systems and searchable databases in this space, and I think that's an area for future work as well. Next slide. And again, I'd like to thank my colleagues who work with us on this, on the elder abuse task force. So thanks very much. And I think Dr. Hastings, you're up.
Great, thank you very much. I'm glad to be here to represent the work of our group that focused on care transitions. Next slide. My disclosures are research grants only, which you can see here. Next slide. So care transitions, or discharge from the emergency department to the community, was the focus of our group. These are, of course, very common transitions, and a number of studies over the past years have documented that they don't always go as smoothly as we would like. The problems can generally be grouped into these three big categories. Medication problems, you'll have really described many of those challenges for us earlier. I won't repeat them. Communication hurdles, communication problems between providers and also with patients and families. And then the last one, which I call the follow-up leap of faith, not leaf, leap, but that not a typo, I called early in time. And here an example would be of older patients that leave the emergency department and return within 30 days. Only about half of them will have seen any type of outpatient provider in the interim time period. Next slide. So these types of problems with transitions undoubtedly represent areas for improvement. However, increasingly, we're recognizing that they might represent the tip of the proverbial iceberg, and that factors that are beneath the surface, like social determinants of health or non-medical factors that influence health outcomes, may need more of our attention. So we certainly know that social needs are common in older ED patients and are significant risk factors for emergency department use and adverse outcomes. Next slide. So this was really the area that our group chose to focus on, which was the intersection of emergency department transitions and social determinants of health. And specifically, we sought to identify the role of social determinants in previously studied transition interventions that involved the ED and older adults. Next slide. So we conducted a scoping review to map this literature. We used a stepwise framework whereby we first identified published systematic reviews. Then we looked at primary papers that were included in one or more of those reviews to find the final pool of eligible papers. For those, we reviewed the full text carefully to reviewers to look at details of how the care transition interventions were described so that we could classify elements that were related to social determinants of health. And we did that classification using the PREPARE tool to identify social determinants categories. Next slide. So here's what our the flow of studies looked like. We identified 11 published systematic reviews that were responsive to our question of interest. In those reviews, there were 246 individual studies that were included in one or more of them. And in reviewing those papers individually, 17 of them met the criteria for our current review and are included. Next slide. So when we looked to determine which interventions assessed social determinants of health, we found that 14 of the 17 included studies addressed at least one. And so this bubble chart shows you those 14. And there's a lot of information on this slide. The colors represent all the different types of transition interventions that we encountered. So everything from discharge planning to telephone follow-up. The size of the bubble gives you a sense of how big the studies were in terms of individual participants. On the y-axis, it's the number of social determinant components that were addressed, and then on the x-axis is the year in which the study was published. Next slide. And if we drill down a little more into the actual categories of social determinants that we're talking about, you can see those here. All 14 studies that included at least one social determinant included the second one listed, which was access to medications or healthcare in all cases. Some of the other ones that we observed relatively commonly were a component of the intervention that was meant to either assess or provide referrals related to social support or loneliness, health behaviors. You can see others listed there. One that we found uncommonly, only one instance, was an intervention that included an assessment of transportation needs, for example. Next slide. So overall, we noted significant diversity among the included studies, both in intervention type and outcomes assessed. There was variable impact on the outcomes that were studied, mostly healthcare utilization type outcomes, but there were some others as well. And we could not discern a consistent pattern between positive outcomes and incorporating either a specific social determinant or the number of social determinants that were addressed. Next slide. So I will end with talking about the research priorities that were identified at the GEAR Consensus Conference, because I think they are well aligned with the findings from our review. And I think that now hearing the final group go, hopefully some of the themes from the overall conference are really starting to resonate. Number one, determining optimal outcome measures was identified as a key need for moving transitions research forward. And we heard this from some of the other groups. But again, we had a lot of studies that focused on measuring things like return to the ED. While that's undoubtedly important, it can be influenced by many things and may not be the most sensitive measure for whether or not a transition itself was actually improved. Number two, this idea of targeting or identifying who will benefit the most from interventions, who are the optimal candidates for support during ED to home transitions. Third, our review focused on ED to home transitions, but the group really wanted to emphasize that something unique about care transitions as a research topic is that it can encompass many different types of transitions. And ED to home, certainly not the only one that warrants more research attention. More study of bidirectional nursing home to ED transitions, for example, was identified as a key area to continue focusing on. The fourth one had to do with data. We know that social risk factors, fall risk, physical function are not often data points that are readily available in the electronic health record. And so we do need to work toward more ways to systematically identify these and make them available to both clinicians and researchers. And finally, the group highlighted the importance of incorporating the perspectives of diverse stakeholders to inform ED care transitions research, so that we really can ensure that we're focusing on the questions of highest relevance and driving toward the solutions of the highest value. Next slide. This is our large and incredibly talented team who contributed to this research, and I thank them all for that. I will pass the mic back to Eula.
Great, thank you so much, everyone. Again, a power pack panel. These are the experts. These are the leaders of the country. Really happy, and you all in the audience are also the leaders. And so you're all wondering, okay, well, I came here to listen. What's going on next with GEAR? So some quick next steps. As I described before, we are in the R33 phase. So we've launched the GEARS study, so the standardization study, and this is a multi-center, 3-site longitudinal observational study at 3 of the JEDC sites, so Northwestern, Grady, and at Yale, looking at patients 65 and older that are coming in through the ED, and we're collecting observational data at several time points. Again, as mentioned earlier, with like guidance from the GEAR Consensus Conference and all the scoping reviews, the importance of not just baseline data in the ED and sort of the early days after the ED, but 30 days and 90 days subsequent. The outcomes that we're gathering really are being informed by the scoping reviews that you just heard and some of the consensus recommendations. And we'll be really taking a look and comparing data that many of us can extract out of our electronic medical record ED encounter data and comparing that to this prospective data that we'll be collecting. GEARS launched this past March. But more importantly, you're all wondering, well, what about funding opportunities? I think the infrastructure that we're trying to build here is really meant for all of you to really be enabled to do more research. We are hoping to put forward pilot funding opportunities that will be released this summer for money that would be used actually then in 2022, 2023, so for a year. There will be two sources of pilot funding, actually one from GEAR and another one from GEAR 2.0, which is an R61, not related, but focused on dementia. So again, be on this lookout. Please check out the website gearnetwork.org. It is currently not, it's a website, but we are building it right now. And this is where we hope to post information for the funding opportunities. Again, they're gonna range in size anywhere from 60 to hopefully around 100,000 of annual total costs. And those funding opportunities will be coming out over the summer and in the fall. But GEAR isn't the only place where you can find additional funding. There are many opportunities that many of you are already aware of, but again, if just to continuously look at websites, not only from the NIH, but also as Tim mentioned, and he'll talk more in a moment about some of the first two opportunities with the NIA and the Department of Justice, but there are partner groups. Again, geriatrics and aging research doesn't sit on just one group of or discipline shoulders. ClinStar is a network now that emergency medicine, geriatrics, many can participate in, and they put out funding opportunities for support, career development support, the GEMSTAR program, NIDIS, the network to investigate delirium in the US, and the Impact Collaboratory. These are examples of other websites that have funding opportunities that I think emergency medicine would be very well positioned to apply for. I welcome my panelists to make some comments, and I'm going to cut and paste and make sure all of these are in the chat.
The ClinStar provides more than funding opportunities as well. It's an opportunity to network with like-minded investigators, both on topic and on methods, as well as mentorship. They've got open office hours. If you want to talk to Tom Gill, who's doing Big Falls research at Yale, you can set up office hours with him to talk to him about your Falls project. So much more than just funding opportunities. Also, annual meetings and webinars about different research topics.
Tim or Nikki, anything you'd like to comment about your experience or Will with these, and maybe Tim specifically around the two that you put in with the Department of Justice, and this one specifically around preventative health.
Yeah, the RFA for 20045 is for a clinical trial that is comparable to an R01 in terms of scale. It's like $400K for the first 2 years, and then 1.3K direct costs for 1.3 million. Sorry, 400K and then 1.3 million for the next 3 years. It's a clinical trial required. Melissa Gerald is the program officer for it, and I think it has good fit with these these subject areas, and it's focused on preventative healthcare in older adults. So I think it's a good option, good overlap in the space. NIJ occasionally, intermittently, will put out funding announcements in the elder abuse space, and it's good to take a look there. And so I think that it's another place to consider. Less money than the NIH, but a different bucket to look at for funding.
I think an advantage of a lot of these opportunities is joining a network, as was mentioned earlier, and that's a really powerful way to build career skills and teams and collaborators. And the one thing that I particularly like about ClinStar is there's an explicit encouragement to connect early career researchers and mentors at different institutions. So that's a really great way to reach out to somebody that's not even at your home site, but has an interest, have a shared interest, and develop networks that way.
There's a question posted as well. The ClinStar would be excellent if it was for non-physicians as well. And I neglected to mention it is for non-clinicians as well. So social work, nursing, case management, pharmacy, all eligible as long as you're in a healthcare related field.
Outstanding. Can you guys hear me okay now?
Yes.
keep going in and out of my audio not working. I apologize, but no, I just want to take a second to applaud you five presenters today on some outstanding work and great information, and the rest of your colleagues in the GEAR network. So I found this very informative. We've got a few minutes left. Everyone on the call that's in the audience, we are on Zoom, so you can unmute, I'd say offer or entertain a question or two if you'd like. I had one quick one, just my own curiosity directed towards you, Dr. Platzmeld. So you mentioned one of your key 5 points for helping to screen and identify elder abuse was potentially incorporating EMS in the system, which I find a fascinating idea. But I was curious, as far as the mandatory reporting that most states do have in their legal system, does that encompass EMS or just the hospital providers, emergency department providers?
Yeah, so 100%. Like if you're a paramedic and you suspect elder abuse, you're a mandatory reporter. Now I'll say, so you should report. Now functionally, there's something that can happen, and this is true in the ED. Like, let's say me and the nurse and the resident and the physician assistant are all like taking care of this patient over a period of time. We don't all have to call APS, right? Like we can sort of say, okay, we know that we have a concern. One of us is going to take on the responsibility of calling APS. Conceptually, and like I'm not advocating, I'm not sort of saying this is a don't like use my name to say legally it's okay, but conceptually, the paramedic can come in the ED and say, you know, Dr. Platzmills, I have a concern about elder abuse. I can call APS, or if it's possible, I'd like you to call APS based on your additional evaluation. I think those sort of handoffs do occur. The spirit of the law is that everybody who touches it is supposed to call, because otherwise the concern is that everybody's like, oh, I thought they were going to call, right? But technically they are mandatory reporters. I think the goal with Detect, with Brad's project, is one is to support the identification, but the other thing is to change the culture around communication. And Tony Rosen and I have done some writing on this, but basically we know paramedics see elder abuse, they come in the ED, they kind of mention it, and the emergency physician will sometimes like not really listen, because for the same reason that we don't tend to want to deal with it, because which sort of goes back to the reporting issue. So I think part of the goal for Detect is to both identify it and then sort of strengthen the culture around like, I'm communicating this to you. I've documented it in the patient care record, the EMS patient care record, and let's make sure we do something about it.
Sure, yeah. No, we just stood up a new EMS fellowship at our shop, so it's got my mind turning on some potential research opportunities there. So for a new fellow, so great stuff. Well, about 2-3 minutes left. If there's another question, please speak up. If not, yeah, thank you all again, and great information and great work you're doing out there.
Wonderful. Thank you so much, everyone.
Thank you.
Thank you,
Thanks all.
everyone.